And welcome back to this Dialogue Web Extra. I'm Marcia Franklin. I'm here talking with 4 guests about the new health care law, and wanted to continue the discussion a little bit after the program. First, there's something that's been on a lot of people's minds, I think, and that is, will there be enough doctors to handle all of the new people coming into the system, whether they be buying insurance or whether they be put on Medicaid? Expanded Medicaid. What's your sense?
Marcia, we have a real problem with health care. We have a crisis with primary care. We don't have enough physicians. So we must increase the production in the pipeline of family doctors, general internists, general pediatricians. We must also use and expand that pipeline for nurse practitioners and physician's assistants. There must be scholarships and loan repayment for those choosing primary care so we can build up the workforce. Right now, if we were to give 32 million people coverage, we would have access issues. Massachusetts showed us that. So it's going to be an issue. We're going to have to work hard at this, but it's the right thing to do to get people on the front end of health care with primary care prevention, health care promotion, as opposed to just the back end of reactive sick care.
Do you think there's going to be rationing as a result? Wait times, long wait times, or rationing of care?
Could be.
What's your sense?
Well, we know we need more doctors in Idaho, and that's something that we know. We agree completely with Dr. Epperly about that we need more primary care physicians. One of the things that we've been trying to do at Blue Cross of Idaho is to realign the way that we reimburse care, and that's one of the things that we would like to see come out in some of this legislation is things that reimburse care differently to encourage wellness and to encourage doctors to enter primary care and not to just enter the specialties, because frankly right now the specialties are reimbursed far more highly than primary care physicians are. So we're trying to realign those payments so that it encourages doctors to stay in primary care and also to get preventive care. We have a preventive care benefit at Blue Cross of Idaho and most of our coverages for that very reason. We want people to stay well.
Because in fact, doctors get paid for doing things to people.
Right.
Yeah, rather than
keeping people.
Avoiding them.
Keeping people well. One of the things that we look at is looking at how we do medical care and and one of the things that Idaho is suggesting is using more of the medical home model, which is really using a primary care physician to coordinate some services and those kinds of things. And that might lessen the burden. Idaho's doing some pretty good things, but they're not doing it quick enough or progressively enough. We've had conversations for the last 4 or 5 years about healthcare reform and what the state can do, and we've got some ideas, but it's just not moving forward.
Another issue that has come up is cost, and that would be the cost of medical care, not necessarily the cost of this act. And I know we have a quote from Governor Otter on this issue. Let's take a listen to that if we could.
Do I think we need to reform health care? Yes. But point me to one spot in all of those pages and all of those briefs and all of those sections where we've driven down the cost of health care.
So, doctors, especially specialists, continue to charge a certain amount of money. What do doctors need to give up in this scheme? Do they need to lower their prices?
Well,
in hospitals?
I think to get to meaningful health care reform, we're all going to have to give a little, quite frankly. And I mean all, from hospitals to physicians to insurance companies to pharmaceutical companies to healthcare device manufacturers. Everybody's going to have to give in a bit here. In terms of the physician aspect of this, what we must do is start to really refocus on health care. We must work with people to help change their behaviors. 40% of the deaths in our country, Marcia, are due to people's behaviors. So if we incentivize us starting to better manage behavioral change through smoking cessation, through exercise programs, through obesity prevention, through better diets, we'll start to see downstream derivatives of that'll save money.
But you still see doctors, and I've had this happen to me, they order tests, very expensive tests. Yes. In part because they want to help you, and in part because they're worried about being sued, I think.
I think that's one of the things that we as consumers have to take a more active role in, and it's partially educating the consumer about this. And when tests are ordered, ask what is going to happen as a result of this test. And many times your physician won't know, and many times the tests are unnecessary.
I know the insurance companies are concerned that cost was not part of this legislation.
We're very concerned about that. And actually one of the biggest things insurance companies do right now, especially as it relates to this specific question you brought up about tests, is we work very, very hard. There are a lot of tests that we require what's called pre-authorization. We won't pay for it unless it's pre-authorized, so that we know that we can look in your claims file and we can see that there was that similar test done, a month ago. So what is the need? We have to have a medical need. Is there a reason for a test to be repeated? Is there a medical need for this particular test at this particular time? These are things that we save money. We save a lot of millions of dollars of our customers' money doing this kind of administrative work behind the scenes.
On the other hand, I have a friend who's a physician who was almost crying one day when she was talking to me because she couldn't get an insurance company to authorize something that she felt would save her patient's life. So you have that give and take between doctors and insurance companies too. I don't know if this legislation is going to solve any of that.
Marcia, can I add one thing here? Would it be okay? One thing we didn't mention is defensive medicine. One of the reasons that doctors overorder things is they're concerned about potentially being sued if they don't find every answer known to man. And so, unfortunately, what wasn't in the healthcare reform bill, to the point that it should have been, was reform of our liability system so that it stops this practice. The other thing I'd just quickly add is that the more integrated and coordinated the care can be, typically through a primary care doctor, you can stop having multiple doctors see people, order things, and not have the primary care doctor know what's gone on with them.
Part of the way that this Healthcare Act is going to be paid for is increased fees on insurance companies and on pharmaceutical companies. I assume those will be passed on.
Well, that's Blue Cross of Idaho is a nonprofit health insurance company. Our administrative costs are less than 8 cents on the dollar. There's no way that we can absorb, a lot of the large fees that are envisioned without passing them on, and that has something that's partly to do with the issue of increasing costs to businesses who buy our insurance. It will be reflected in the increased costs and the premiums. It can't help but be that way.
And people at a higher income bracket are going to see higher taxes for this.
Well, and it's not just the increased fees to insurance companies, to pharmaceuticals, and to durable goods manufacturers. It's also the mandated products. People are going to have to buy more Cadillac plans than they used to. We think that we're going to have to buy less products. The products are going to have a lot stronger benefits than they currently have at a lot higher prices. Younger people are going to pay a lot more for their coverage. People who get discounts for being healthy now are going to pay a lot more. The discounts will be gone. There's going to be some people are going to win on this program, but more people are going to pay a lot more than they used to in the past.
Well, let's take some phone calls that have been holding for quite some time. Craig and Haley. Craig, go ahead, please.
Yeah, currently I have a policy with a high deductible. It's like $5,000, and most of my medical conditions, that I've gone to see a doctor for, cost less than that $5,000. So essentially my insurance is worthless. I've been paying it for 40 years, ever since it was $29, and now it's gone up to $350, which I assume is pretty inexpensive. But it's all I can afford. And my wife had to cancel her insurance because we couldn't afford both policies. So is this new law going to eliminate the deductibles? Is it going to become more affordable, for us now to go to a primary caregiver and get, care that we need without having to double our costs, pay for the insurance and pay for the doctor at the same time? You understand my question?
Yes, absolutely. And then I talked to my hairstylist, and she's in the same position. She has, she and her husband are on a $700 a month plan, with each of them having a $5,000 deductible. He just had kidney stones. It was $4,500, so that came right out of her pocket, no insurance.
Well, Craig, one thing I would tell you is since you had that plan on March 23rd in the year 2010, you have a grandfathered plan. You may not be able to have an opportunity to buy a $5,000 deductible at that kind of price ever again. You might be forced to buy a $500 deductible at $900 a month, and if you don't do it, you'll be penalized on your tax return. So this could be something that you're extremely lucky to still have access to.
But Dr. Epperly, and anyone can correct me, there's going to be an insurance exchange set up with supposedly more competition, and also subsidies. I don't know what you make per year, Craig, but there are going to be subsidies to help people buy their insurance. and they're quite high. It's up to 400% of poverty level, which is like $40,000 for an individual.
The Public Law 111/148, Marcia, puts in within all 50 states health insurance exchanges so that there will be more competition. You can go to a computer screen, to a website, one-stop shopping, and find a plethora of different plans. And the companies will have to make sure they've got a viable product or they will not be able to sell that product. And so it's going to charge, I think, the companies with a lot of accountability to make sure they've got good products in place. So Craig, to you, I would say that this will be very good for you. You can take a good look at the whole plethora of different options you have and find one that will meet your need. Again, when we get outside of the United States and look at what other countries have done, they've been able to answer these questions by having a comprehensive health care bill in their countries, laws in their countries that have allowed them to do this.
I have to beg to differ, because actually there won't be a plethora of options. There may be a plethora of companies, but the options are not going to be anywhere near what they are now. Right now in the state of Idaho, we have limited benefit plans that allow people to buy insurance to cover their basic needs for a very small amount of money. I mean, under $100 a month.
But he's talking about those deductibles.
And the deductible on that particular plan is actually very low too. It could be $1,000. So right in the future, however, those plans won't exist. Those limited benefit plans will go away because there will be requirements of minimum coverages, which are much richer benefits. If you offer richer benefits, it does increase the cost of that insurance, and exactly so, which is why there's one of the things in this bill has to do with grandfathering in, allowing people to continue to purchase what they purchased in the past, which will allow people to buy insurance at lower rates than will be available in the future, as Steve just said.
Craig, I think the jury is still out. You can hear that there are differences of opinion here, and we're just going to have to see when these exchanges are set up how it's going to go. You know, whether there's going to be more choices with lower deductibles or not. But I know that there's many people in your situation, and I appreciate you calling in. Good luck.
May I ask one more question, please?
We've got about 4 calls holding, so unfortunately, I don't think we have time for that. But if you want, you can call in with your number, and I can try and get somebody to help you offline, if that would help you.
Okay, well, thank you for your time and answering part of my question.
Thank you very much. I appreciate that. Let's go to Dorothy in Ammon. Dorothy, go ahead, please.
Hello. My question is, what about people like me who have to be on alternative care because they're allergic to prescription drugs and no insurance company wants to accept you?
And what do you mean by alternative care? You mean herbal remedies?
Yes, and other treatments like massage and chiropractors and things, because nobody. I'm a new person here in Idaho. I've only been here close to 2 years, and I have called close to 30 doctors to get a primary care doctor. And there doesn't seem to be enough to go around. They say they don't, and after listening in on your conversations and everything, I think that is something that is lacking in this area, is primary care doctors, because everyone I've called says, we're full up, we don't have room for you.
Yes, this is going to be a concern, I think, is whether we have enough
too
doctors.
many
But let's get your question answered about what's called complementary medicine, because it's a very good question, Dorothy.
Well, there's so many people, and I got CNN to run a poll, and they said there was 68% of the people used some sort of, and we're being left out.
Alternative medicine.
Yes, we're being left out.
Let's get an answer to your question. As I mentioned in a previous graphic, certain preventative, some things will be covered. And as I understand, you cannot discriminate against people who are working under certain licenses like chiropractors, acupuncturists, naturopaths. In this state, however, my understanding is chiropractors are licensed by the state, but say hold on a second, Dorothy. Massage therapists, acupuncturists, naturopaths aren't. So I don't think that this new law, at least in Idaho, would cover complementary medicine in those areas. Is that correct?
Well, as far as working within a scope of license, there has to be medical necessity, and it has to be a medically appropriate thing under someone's license. If they aren't licensed to provide care, there's going to be no way to make sure that the quality of that care, I mean, there's no one monitoring the quality of the care that exists. So it's a very difficult thing to look forward to. Even this, I don't think this legislation envisioned that. Certainly operating within the scope of licensed chiropractors, I believe that massage therapists are licensed, but they can operate in the state without licensing. So it's not a requirement in the state of Idaho to be a licensed massage therapist.
It's kind of a state-by-state thing. I do know from reading about this before the program that wellness practitioners are going to be at the table for a lot of discussions, including about cancer treatments and things like that. So there are some provisions in the law, Dorothy, but I don't think that it fully addresses your situation.
Well, how do I go about finding? I don't have money to pay penalty and still buy the alternative care.
Right.
And so where do I go? I'm left out in the cold without insurance or anybody that will accept me.
I think that it's a good question about complementary medicine and how that's going to be covered. You can certainly will be given opportunities through Medicare and Medicaid to help purchase insurance, but it will go to more traditional physicians. Dr. Epperly?
Marcia, I'd just add that part of the healthcare reform bill is to do is to look at what's called comparative effectiveness research.
Right.
Which starts to use, Dorothy, an evidence-based approach to take a look at what the science really says about alternative medicines and acupuncture, massage therapy versus other sorts of treatments, so that we can have effective answers for what works.
I've had 16 surgeries, and I think I've seen on both sides of the spectrum here. And in Colorado, I wasn't having such difficulty finding.
Right. It is a state-by-state licensure issue, Dorothy.
And
thank you.
Here, you just can't. I think the problem is there's just not enough alternative care doctors to go around, or not. I didn't mean. Excuse me. I meant PC doctors, primary care doctors.
I think everyone at this.
I can't get into one.
I think everyone at this table is in agreement, and there is money in this legislation to encourage more education for primary care physicians, and frankly, to give them more money, more reimbursement for seeing Medicaid patients. So the hope is, Dorothy, that in a few years we'll see more nurse practitioners and more primary care physicians. Thanks so much for your call.
Hope so.
I'm sorry I had to cut her off, but we do have Doug holding from Idaho Falls. Doug, go ahead, please.
Yes, thanks, Marcia. I would like a very simple yes/no answer from each one of your guests tonight. Have you personally, not been briefed, but personally have read the 2,076-plus page bill that was signed off?
Okay, and to what effect, why are you interested in their answers on that?
Validating, because there's a lot of information that is being given over from these four individuals, especially from Dr. Epperly and the gentleman for AARP, Jim Wardelman. But I'd like to know, have they actually read the bill?
Okay. Fair enough.
Yes, no.
I don't think any of us have the time to read 2,076 pages, but all of us have certainly read important summaries of all the provisions of the bill.
And you were back and forth with D.C. working on certain provisions of it, as I understand it. Anyone here read the whole bill? I haven't read the whole bill.
Well, the bill wasn't even published. Yeah. I don't think the people who even voted on it actually read it. There wasn't time. That's one of the problems that we've seen with this bill.
We've had staff at our national office in D.C. who have read the entire bill page for page, and that's where we get our analysis. Yeah.
Well, indeed, we at the Blue Cross Blue Shield Association also has provided us with extensive, and the American AHIP as well, provided us with extensive summaries of the bill and have read through all the sections of it, had it basically read all over it. So we do, I agree, we've read the summaries prepared by numerous people who are very knowledgeable about it, but I don't think I agree with Dr. Epperly. There hasn't been time to read 2,700 pages.
I didn't know where to see it. Online, I guess.
Thank you very much for your call. And let's take a call from Sandra in Boise. Sandra, go ahead, please.
Hi, everyone on the panel. I have kind of a tailored question. I have heard several times that the insurance is very low here in Idaho compared to other states. I am a unemployed person who has never in my lifetime been without insurance. I'm 63 years old, and I was searching for insurance, and I did go to Blue Cross Blue Shield of Idaho, and my first amount that I was given that they came back with was $165, and that was with pretty basic insurance. And then they tailored it to me and my problems, which are very minimum. I take one medication, and that's it. And I don't visit the hospital that much. Mm-hmm. And they came back with a quote of almost $500.
$500 a month.
A month. Now, for someone that's unemployed, that's extremely high. So I'm just wondering where the figures are coming from that this state has very low insurance. I think it's for people that are very healthy, that maybe don't have any problems, or not taking medicine.
Well, just as far as
Sandra.
Steve, that one quickly. I'm sorry, Sandra. Quickly, where the analysis came from, that the rate of our insurance in Idaho being lower by 11% than the national average and 25% lower than the most expensive state, comes from the Commonwealth Fund's analysis, not a Blue Cross Blue Shield analysis, but the Commonwealth Fund's analysis of healthcare costs across the country. I think you would find that it is expensive. As you grow older, insurance becomes more expensive, and if you have medical issues, it does add to the cost. If you sought out insurance in other states, it would be even higher.
Does she qualify for Medicare at her age? Or?
No. Not unless you're on a Social Security disability, then you would be qualified.
Yeah. But Marcia, I would just add that's exactly why we need health insurance reform as part of this bill. If Idaho's the lowest, and it's costing Sandra $500 a month, that's not right. And that's why we need to have reform that's meaningful, that will start to lower premiums for people just like her.
Ted, her price won't be below $500, though. It'll still be over $500. And the worst part is the young people that really don't have the claims that you have when you get older are going to pay a whole lot more than what they should be paying as well.
But how do you know that? How do you know that 5 years from now, 7 years from now, 10 years from now, 20 years from now, that's a true statement?
Well, I know in 3 years from now, when the minimum policy standards go in play and we know what composite rates look like, that'll make that a true statement. And they can charge, even at her age, she can be 3 times higher than than the lowest rate. Someone who's 20, they can be 3 times higher. So with an improved benefit and the 3 times spread, it's $500 is going to look cheap compared to
she's unemployed. So my sense, when you're unemployed, is you're not making much money. So under this new act, though, she will qualify for subsidies, including Medicaid. Right. Medicaid has been expanded to 133% of the poverty level, Sandra, and it's going to phase in. It's not going to be immediate. But my sense is, if you're unemployed and your income is very low, you will qualify to be on Medicaid. Okay. And I'm not a doctor, and I don't even play one on TV. But this is part of what the act was directed at, is people like yourself who are kind of stuck there. So
I have one little more question, and I promise you I will get off. I have been very ill. I have been hospitalized 3 times. Each time not being employed, and also for the first time in my life not having insurance. I had to ask the hospital to pick up that bill.
Right.
One bill was I think it was $40,000. Another was $50,000, and then I got a private firm here that I think it's run by the state that took care of another one. Now, and these are for your 2 panels that were sitting on the right side of my television. I got it late, so I don't know their names. Sorry, the female and the man. And
the insurance.
Yes, exactly. That money comes out of the state, and it's paid by people who work and from their taxes. Am I not correct?
So your hospital bills are paid for by a combination of what's uncompensated care from the hospital, charity care, and you're right, the county's catastrophic fund. So it's generally a combination of taxpayer money and hospitals giving you care, which then they pass on to other individuals in their bills.
Uncompensated care, the cost of uncompensated care is shifted to folks who pay insurance right now.
And the Act is trying to get at this issue, as I understand it.
Right. So my question is that which is the worst? This new bill that's coming up, that's been passed, that's going to cost us money, but people will be insured, or people like me who have gotten the state or private state firms to pay my bill, which is the worst evil? I've heard that California, this is one of the problems why California has done so badly.
Let's get an answer to your question. This is one of the cruxes of the debate. Indeed. Are we paying more for people like Sandra who can't pay her bills in our insurance premiums, those of us who are insured? Or will we pay more when people like Sandra are brought into the fold? And I think it's yet to be determined.
The jury's still out on that one.
I think.
The really unfortunate thing is, it's really unfortunate when people want to use charity, whatever, and help out someone like in Sandra's situation. That's great. But when you make people give up significant amounts of their own earned income to make up so somebody else can get it for free, that's where we cross the line.
Marcia, the jury's not out on this in the world. And when you get outside of the United States and you look at what other countries have done, it absolutely saves money to the nation, and people like Sandra are cared for. It's the right answer in terms of broadening coverage to as many people as possible and keep her from fearing what I just heard in her voice, and that is that she's one diagnosis away from bankruptcy or one diagnosis away from just totally being on total state aid.
Sandra, we wish you luck. Thank you so much.
Thank you.
Thanks so much for calling. And thanks to all my guests for staying and answering all these phone calls that came in. I really appreciate it. It shows the depth of emotion in some instances in people's voices for what they're going through. And we will continue to cover this story. You've been listening to a Dialogue Web Extra on the new Healthcare Act. I have Karen Early here from Blue Cross of Idaho, Steve Fredrickson from Fredrickson Health Insurance, Jim Werdelman from the AARP Idaho, and Dr. Ted Epperly from the Family Practice Residency here in Idaho. And thanks for tuning in. We hope you'll join us again in the near future.